Welcome back to the Obesity Prevention Summit. Through the day during the summit, we have spoken about this silent epidemic, the burden it has on our healthcare system, and the need to nip this problem in the bud because this can lead to many, many other health complications. Now, India accounts for 1 in 7 people with diabetes worldwide, and over 6 lakh people in India die from the disease every year. This is second only to China. A person with diabetes who is overweight is more likely to develop several comorbid conditions, including certain cancers, bone problems, heart, kidney, and liver diseases, in addition to high blood pressure and cholesterol. So, if you have obesity, you have 6 times more chance to develop type 2 diabetes than those with a healthy weight. Of course, not everyone with obesity automatically gets diabetes, but weight management is a key component of holistic type 2 diabetes management. Every 1 kilogram of weight loss can help lower HbA1c. Therefore, it is essential that people comprehend the significance of securing the link between diabetes and excess body weight by talking to their physician about the novel medical treatment options for weight management in type 2 diabetes. This session is being sponsored by Novo Nordisk, and we are very, very grateful for our expert doctors who have taken the time to join us today. Please join me in welcoming Dr. Sujoy Ghosh, diabetologist and endocrinologist, Department of Endocrinology, Institute of Postgraduate Medical Education and Research, Kolkata. Please also welcome Professor Dr. Anup Mishra, Director, NGOC, President, Diabetes Foundation India, and Executive Chairman, Fortis Doc Hospital for Diabetes and Allied Sciences, and Dr. Banshi Sabu, President, All India Association for Advancing Research in Obesity, AIAARO, and Chairman, Dia Care, Diabetes Care and Hormone Clinic, Ahmedabad. Thank you, gentlemen, for joining us for this very crucial session on the link between obesity and diabetes. So let me ask you, Dr. Sujoy Ghosh, can you tell us a little about this growing burden of diabetes and overweight or obesity? Is there a direct correlation, and is this growing as a problem?
I think if we look back upon our younger days when we went to school, you would have maybe 1 or 2 kids in this class who were overweight, and there was a bit of body shaming, which we were not aware of at that point of time, which is very, taboo at this point of time. But when I look at my daughter's class and look at the kids in their class, quite visibly, the BMI has changed. And if you look at all the national surveys that we have data from, whether it's the National Family Health Survey 3 versus 4, there is a significant increase in the proportion of individuals who are either overweight or obese. And this is across age groups, this is across genders. And therefore, we realize that this is one literally growing problem, a big problem. And we know that majority of the non-communicable diseases that we talk about, whether it's obesity per se, whether it's diabetes, dyslipidemia, fatty liver disease, cancers related to obesity, the main driver is obesity. So it's fueling this pandemic of non-communicable disease in India. So this is something that we need to worry about, because in the years to come, the young kids that we have today will grow into young adolescents who are obese adolescents. They will grow up into overweight and obese adults. And therefore, what is like, say, 13 to 15% prevalence of diabetes in India at this point of time, which is, of course, far greater than what it was maybe a decade or 2 decades ago, is going to increase even further. Look at countries in the Middle East. Prevalence of diabetes close to 30-35%. So we will go that way in the next decade or 2.
So, Dr. Sujoy, you're saying there is a direct correlation between the overweight and increase in diabetes in our country?
Yes.
Sorry.
Yes, Dr. Sujoy. Would you give me a brief?
I just lost you. Sorry, if you could repeat.
So, my question is, and very briefly, would you say there is a direct correlation in the increase in number of patients with obesity with the increasing number of diabetes patients, or is this coincidental? Dr. Sujay, the question is to you. Is this coincidental that the rise of obese patients matches the rise we're seeing in diabetes patients, or is this coincidental?
No, it's not at all coincidental. If you look at the Western world as well, who have gone through this transition of rise in the prevalence of obesity and the prevalence of diabetes, there is a direct correlation. So if I actually have to say, what do you think are the two most important risk factors of diabetes? One would be, of course, the genetic background that we are talking about, and would be the change in body fat and the proportion of body fat. So people who are more obese in a background of genetic susceptibility will develop diabetes type 2. So it's not a coincidence. It is almost a predictable pandemic that we are seeing. And therefore, we call this pandemic diabesity, that is diabetes related to obesity. So it's not at all a coincidence. It's the driver. Obesity is the driver of this pandemic of diabetes.
All right. Uh, Dr. Mishra, now obesity is not exactly seen as a disease. It's people describe it as a lifestyle, body shape, whatever. But diabetes is a known disease which requires treatment in many people. What are some of the complications associated with type 2 diabetes combined with the person being overweight or obese?
So there are two parts of your question. One is your statement that obesity is not a disease. That's incorrect. And if you look at the obesity, there is a dichotomy. Uh, there is a person who's obese, who has excess body fat, but doesn't have any much of a problem, doesn't have a locomotor problem, doesn't have a liver problem, doesn't have diabetes. He probably doesn't have obesity as a disease. But if you look at the obesity, as Sujoy has mentioned, leading to multiple other problems. For example, let's say obstructive sleep apnea, patient has a problem in the sleeping at the night, diabetes, has hypertension, he has a problem in locomotion, has problem in breathing or palpitation because of obesity itself, then obesity is a disease. Now, the moment you combine diabetes and obesity both, we have much more complications. So, if you look at the diabetes, people with diabetes who are thin versus people with diabetes who are obese, these are two different people, and complication rates are also different. So, those who are thin and have diabetes have some different mechanism of diabetes, but they have a small arterial disease, a small vessel disease more often. But if you look at the patients who are obese and diabetic, then they have a big artery disease. Big artery disease means arteries in the heart, arteries in the brain, arteries in the foot, and also have certain other problems, and specifically the fat in the liver, which leads to the dysfunction of the liver. So as you can see, these two different profiles, but more problems in patients who are obese as well as diabetic, because they are going to have these problems and then further locomotor problem. They will not be able to exercise, and problems will multiply in no time.
All right. Dr. Sabu, it seems to me after listening to both the two doctors that if you're overweight and you have diabetes, you have big problems. In terms of economic implications, will healthcare costs also increase if I'm diabetic and obese versus diabetes and not obese?
So your point is that somebody is obese and there is a diabetes, and somebody is non-obese and diabetes, whether the cost will increase or not. I mean, the economic aspect, one I can say with the persons with obesity, with diabetes, there is a further increases the risk of some more complication. And because of that, there is an increasing risk of the cost also, because the cost will further increase if somebody is going to develop more heart disease, more of liver problems, because a person with obesity with diabetes are going to develop these complications more. But direct cost, If suppose if somebody is non-obese or obese diabetic, it may not be necessary because a non-obese person may require the therapy, which may be equally costly. Nowadays, there is a therapy which is we use it for a person with diabetes and with obesity. The medicine which also helps not only for weight management, but also for control of sugar, that is a bit more costly. And that's the reason we can say a person with diabetes and with obesity, there is an increased cost of a therapy in compared to the person who is having diabetes but not obesity. But yes, with the person without obesity, they are also more insulin requiring patients. They are more insulin dependent or more insulin deficient. So sometimes their cost may be also increased. So direct cost of therapy, if I just calculate, it may not be necessarily that it may increase or not. It is individualized case, but definitely the patient with obesity have higher complication. So that indirectly it increases the cost. And here some of the therapy which we now use for obesity management along with diabetes, that increases the cost of therapy for diabetes patient with obesity.
Okay, so I was under the impression that you treat obesity by changing your lifestyle and your diet and improve your diet and increase your exercise. But I'm sure for people who have a medical problem, because obviously there are medical protocols as well to lose weight. But Dr. Ghosh, is it difficult for type 2 diabetes patients who's also obese to lose weight as compared to those who, you know, are fat but don't have diabetes and they could go on a regimen and they lose weight? Could you help us here?
Right. Uh, the the statement that you made was, in terms of about weight loss being more difficult in patients with type 2 diabetes is a reality. Now, there are essentially several reasons why that happens. For example, if I have poor blood glucose control, one tends to lose a lot of calories through the urine in terms of glucose loss and calories through the urine. The moment someone actually then goes and has medication for blood glucose control, that blood glucose level comes down to near normal. So the calories that you were losing through urine, you no longer lose them. So even if you're eating the same amount before good control versus bad control, you will have a tendency of weight gain with any kind of medication that you are using for management of diabetes. So that is one aspect. So that's one reason why people with diabetes with improving glycemic control will have a tendency of weight gain. There are certain drugs which make things worse. For example, pioglitazone. For example, the sulfonylureas. For example, insulin. Which are anabolic drugs, which will increase weight as well. So forget about weight loss. You're more likely to put on weight. The rest of the drugs that these patients take are usually weight neutral. Now, there's only two classes of medication that diabetic patients can use. One is the GLP-1 receptor agonist drugs and the SGLT2s, which help weight loss. That's one bit. The second bit is, how do you lose weight apart from modifying your medication? One would be diet and exercise, right? Now, Professor Mishra quite clearly told us about risk of complications, particularly microvascular complications or even macrovascular complication. Imagine somebody's got problems in the foot, somebody's got problems in the eyes, or somebody's overweight with diabetes. You ask that individual to exercise. Physically, how viable and possible is such physical activities? You might be having a problem with your foot, unable to walk, exercise, unable to see properly, having vascular problems, having pain in the foot. So a multitude of factors actually make weight loss in individuals with diabetes very, very, very difficult. And if you follow up studies and you compare people with diabetes and without diabetes, with obesity versus those without obesity, you will see that fat people or overweight people with diabetes have much bigger problems in terms of being able to lose weight. The worst bit is, even if you've lost weight, it's even more difficult to maintain what you've lost or sustain the kind of weight loss that you've had in the long run. So, we are fighting a difficult battle. And we also know that, this complex relationship between weight and good blood glucose control is a bit tricky. For example, we all say, get your HbA1c down. So every 1% HbA1c that you get down, if you put on 3 kilograms of weight, you kind of offshoot that benefit. So it's a chicken and egg story. You try on one hand, try to reduce the weight. On the other hand, you try to reduce the A1Cs. And it's not necessarily that both the parameters go in the same direction. You would want both of them to come down, but unfortunately, it does not come down in a lot of circumstances. And that's why I think it's important that the newer drugs that we are getting, the new kids on the block, are probably better in terms of outcome because they reduce both the glucose as well as the weight.
Okay, so that's some good news, but it was sounding quite difficult for overweight patients. Dr. Sabu, what have you seen in your experience? I'll give you an example of a friend of mine. Her mother was overweight and she had diabetes. And because of her overweight condition, her knees started to trouble her. So she couldn't walk. She couldn't walk, she couldn't lose weight. Because she wasn't losing weight, she was having problem, controlling her diabetes. And because she was not moving around, then she lost her appetite. But still, her diabetes was not going under control. What do you see in your experience?
So we see these type of patients very commonly. So the person with diabetes, with having already obesity, having some osteoarthritis of knee, not able to walk, not doing the regular exercise. But there are some exercise which can be done even with the persons with knee problems, which is like yoga, doing in a chair, sitting position, doing some upper limb exercise, not not putting a lot of strain on your lower limbs or on your knees. But other than that, we can reduce the weight of the persons by modifying the diet. What is the problem in our Indian diets is mainly the carbs. People think that if they are not eating the fat, it means they are doing dieting. They are controlling their calorie, but it's not true because actually the carbohydrate content of our diet is very high. The total calorie is very, very high. And the carbohydrate in that is very high. So we take 3 chapati, 4 chapati. So that is to be changed. That requires more of a protein. It requires less of simple carbs. It should be more of complex carbohydrate, more of fibers. So these some modification if we do, that will increase the satiety. It will also decrease the total quantity of the food. It will also decrease the total calorie content of the day, and then definitely will help the weight reduction. It will also help in control of the sugar, because if carbohydrate content is reduced significantly, the post-meal glucose will also better control. As Sujay was talking about the newer drugs, these newer drugs will also help for a better control of the sugar, but at the same time for weight reduction too. So the molecules like the GLP-1 analog, which had come and now it is available in India in oral form also, which we give, which significantly reduce the appetite, which helps for the whatever the diet which we plan for the person with diabetes and with obesity, they take care of it. And along with that, SGLT2 inhibitor, which helps not only for good control of the sugar, but they are also cardiorenal protective and they also reduce the weight. So these are the two newer molecules along with the metformin and the molecules which are weight neutral. When we prescribe these type of medication, we find there is a weight reduction that improve the glucose control. They are also complication preventive medication, because long-term diabetic patients and obese patients are going to develop or may develop heart problem or kidney problem. So that can be prevented also. And this weight reduction will help the female which you are describing will also help her in reduction of the pain. But still I will ask her to do some exercise which can be easily done. Some of the exercise even without straining the knee, still she can do some of the exercise, and with weight reduction it will help further, not only for her knee pain but also for her sugar control also.
Right. Dr. Mishra, can you explain to us what is the upstream approach to type 2 diabetes management?
See, you can say upstream, you can say forward approach, or you can say new thinking. I think what we should use the word is not upstream, but that how new things have evolved to change our thinking in a way best to help the patient, where we were not probably able to help previously. So what is the new thinking and what is the old thinking? The old thinking was the glucose-centric approach. You know, as Sujoy said, that when we were in the schools and colleges and our medical colleges, uh, only thing which needed control was sugar. That's all, nothing else. There were two drugs, and we could use those drugs and plus insulin to control the sugar. But that thinking has overall changed over a period of time. Because ultimately, what are we doing by controlling the sugar? We are trying to protect the organs. And so, from the so-called glucose-centric approach, it is my term, organ-centric approach. And what organs we are going to protect? Number one is heart. Heart is always number one. What would be number two if I ask the question to a group of students? And they will say kidney, eyes, but that's not the second one. Second one, and that's also forward-looking thinking, the new things that we have learned over a period of time by research is liver. And currently, apart from heart attack, the liver cirrhosis is number two as far as complication. It's not a direct complication of diabetes, but it is a possibly complication of obesity. So obesity plus diabetes makes it worse. And then, of course, you can go on listing, the nerves, the kidneys, and things like that. To me, these two matter a lot. I have to preserve these in the best possible manner. That's why choice of drug now depends on the organ being involved or organ at risk. So there are two things. One is at risk. Today, my organs are okay, but they are at risk for heart attack tomorrow. Or my organs are not okay and already damaged. In both situations, we can help the patient in a better manner because we have better drugs. So a group of drugs, SGLT2 inhibitors, they are very organ-specific drugs. In fact, their glucose-lowering properties are not so much. It is the organ protection properties which are a lot. And similarly, as has been mentioned both by Dr. Banshi Shabu and Sujoy, the glucagon-like peptide 1 receptor agonist. This is the total name. There are multiple drugs, injectable and oral in this, which are perhaps some of the best and the most exciting drugs to come into the diabetes arena. Why? Why are we saying so? Because they will target weight, they will target heart, they will target also kidney to some extent, but also target brain, which has never been targeted by anything else. This is something miraculous. I probably in the student days would never dream of having such a drug. The only problem becomes that these are injectable drugs or they have little expensive. That is the only roadblock. Apart from that, there's none. So in last 10 years, we have gone far ahead. And with this organ-centric approach, I'm sure people like Dr. Banshi Shabu, Sujay Ghosh, and all of us are saving many more lives today than we were doing 10 years back.
Right. Dr. Mishra, this is very, very interesting. You said these new drugs protect the organs, but do they help reverse diabetes as well?
They once these two drugs, SGLT2 inhibitors and GLP-1 analog, they have, and the recent ones, they have a propensity to cause major weight loss. And some of the recent drugs have achieved a weight loss of 10 to 15 kg or maybe 20 kg, which is seen only with bariatric surgery. Now, bariatric surgery is magical modality. It puts diabetes in remission and off medicine in 60 to 70% of the chosen patients. Same thing can be done with the drugs now. So, Once they are here in India, and there are some drugs already here which are of slightly lower potency, and more potent drugs will be there. Probably need for bariatric surgery will go down. These patients, when they respond to the drugs, their diabetes will automatically decrease as far as sugar is concerned. Need for other drugs, other insulin will decrease, and actually they'll be much better off financially also. We were talking about the expense of these drugs, but expense of other drugs will come down once they become better and when they lose weight.
All right, that's very promising. Uh, Dr. Saur, just a question. Are these kind of drugs only prescribed for uh, obese patients who have diabetes? Because everybody is interested. Those who are obese or overweight, they're keen to reduce their weight, even if they don't have a health complication yet. They may be at risk. They don't have a health complication, but they want to look better. So can they just go and buy these expensive drugs and avoid liposuction, other those kind of surgeries to reduce their weight and get rid of obesity?
You're continuing with me?
I'm asking Dr. Sabu, can you have these
Sabu.
advanced medicines only to lose weight if you don't
Yes.
have diabetes?
So now these medications are also for the research in persons with obesity too. And there are molecules, GLP-1 particularly, we are doing clinical research only for obesity without diabetes. Some of these molecules which are available to India and many parts of the world, doctors are prescribing these molecules off label, not officially. They are labeled as only for to be prescribed for obesity patients, but off label people are prescribing and they are getting benefits too, as we are getting the benefits of almost 5 to 10% of weight reduction with these molecules, and people are prescribing and getting the benefits. But we have to explain the patients with obesity or person with obesity that this is at present is a off label. It is not. But yes, in India, like the molecule which is liraglutide, which was available as a 0.6 and 1.2 unit as a anti-diabetic agent, which also helps for the weight reduction. If we use it in a 3 milligram composition, which is available in a US market they have kept as a separate brand, and that is used as an anti-obesity agent, which is approved officially in US as an anti-obesity agent, and they are prescribing that agent also as an anti-obesity agent. So suppose if I want to use the same molecule in India, I have to tell the patient that this is the molecule which is available in India also, in international market also it is available, and we do write this as an anti-obesity agent, and if you are okay with it, we can write it. So after explaining, we do write, and many of us endocrinologists across the country, all the practicing physicians who are practicing obesity, we do write and we get the result also. But roughly around 5 to 10%. But it is the lifestyle modification, how you educate the person with these medications, that is also very, very important. So it is not like that some magic bullet had come or some magic medicine had come and you just write and the patient will lose the weight by 20 kg or 30 kg. It is the how lifestyle modification and how much you can change the perception, and lifestyle is to change. And then it's a lifelong. It's not for a few days or few months. It is like lifelong. You have to change the lifestyle, and then you can have the weight reduction, and then the maintenance of that weight loss is to be also maintained. That's very important.
Right. For maintaining, then you will have to bring in lifestyle changes as well. So I'm
That requires
guessing
a lot
that
of education. That requires a
yes,
lot of education.
and no matter how much medicine advances, no matter how easy it becomes to lose weight by popping a pill, to make a long-term difference to your life, you will still have to make those lifestyle changes so that you can keep those benefits for the longer time. Uh, uh, Dr. Joy, what are the clinical benefits of weight loss?
Right. It just continuing from where Dr. Bansi left, you were talking about drugs which could be like magic bullets for weight loss. Some of those drugs are still not being launched in India, and you will be surprised to know the major reason is because the companies are unable to make enough of it. Because in the Western world, people have gone berserk and have been using these drugs left, right, and center. They've been asking their physicians, even if they don't have diabetes, to prescribe these drugs. So that's just an anecdote of what's happening in the Western world. And in terms of benefits of weight loss, now, of course, you'll have to think of what kind of weight loss am I having? Is it a 5% weight loss, 5 to 10% weight loss, 10 to 15% weight loss, or even up to 20% weight loss? So the quantum of weight loss is an important determinant of what benefits we get. Secondly, is it sustained weight loss that we have? And thirdly, what or where was I to start with when I started having the weight loss? So the more obese you are, the more morbid conditions or comorbid conditions you are, the absolute proportion of benefits are going to be even that much better. So traditionally and conventionally, we've been taught that you should target for a minimum of 5 to 10% weight loss, and that about 7% weight loss gives you most of the metabolic benefits. That means you will find that the blood glucose comes down a bit, the blood pressure comes down, the lipid profile improves. Now, the reason why people always talk to us about this kind of a target was because you didn't have the weapons or the means to lower the body weight beyond that medically. Now, the drugs that both my seniors have talked about is drugs which can reduce weight up to 15%, some studies up to 17 to 20% weight loss in some group of individuals. So we do understand that maybe 5 to 10% gives you some benefits like the weight, the glucose, and stuff like that. One of the things that you were talking about is diabetes reversal, which is being very loosely, colloquially used in today's world. It's actually not reversal. It's a partial remission of diabetes that happens probably for a certain period of time. And that would happen when you've lost, say, somewhere around 15% of the weight loss, not before that. So if you're looking at the simpler benefits, it'll happen in 5 to 10%. But if you're looking at the obstructive sleep apnea, if you're looking at the osteoarthritis of the knee pain, the liver improvement, the reversal of diabetes, the reduction in the risk of having malignancy, these would be the benefits, but each of those benefits would be sustained over a certain range of weight loss. So for example, the blood pressure benefit would be sustained even at about, say, 15% of weight loss. So amongst those metabolic parameters, the blood pressure parameters, the lipid parameters, the liver dysfunction, the sleep apnea, and the diabetes, all of that can improve, but would improve depending on what proportion of weight an individual actually loses and is able to maintain that degree of weight loss.
All right, Dr. Mishra, these new age obesity control drugs seem to be these miracle drugs. Do they have any side effects which are perceptible and people should be warned against? Because, when people are obese, they are known to do, some of them are known to do drastic things. They start popping in unregistered drugs or, like supplements or, we've heard of some cassia cambogia, some of these drugs, green coffee, whatever natural products or otherwise. And then what happens is some of the other organs get impacted, like the liver gets impacted by these harsh toxins which are there in these unregistered drugs. So are these completely safe to use, the newer age drugs that have been developed? Dr. Mishra, you're on mute. If you could unmute yourself.
Yeah. So that's a very important question that you've asked because this is very important for the general public to listen to the answer. Number one is that there are a number of unregistered, sort of a qualified drugs which are in market. And if you go to a health shop, you will find so many supplements and so on. You may have heard of recent mishaps with some of those drugs, and one of the senator's wife in US took one of these drugs and died recently because of liver problems. So be careful there. They may look very attractive, but in some people, they may cause huge toxicity. And hence, you need to have your physician into confidence when you are looking at such supplements. That's number one. Number two, the answer your question. Yes, Our drugs, whichever you use, either SGLT2 inhibitors, which have some weight loss, not as much as the GLP-1 receptor agonists, have some side effects. But those side effects are very well known to us because they have been researched in thousands and thousands of patients over years together. We are very sure about these. We can tell you the percentage of people or type of people who will develop the side effect. And side effect could be in GLP-1 receptor analog, nausea, vomiting. That's how its effect actually starts. And this may go on for some time, maybe 3 to 4 weeks, after which in most of the cases it resolves by itself. So this can be managed very well. And in some people, the injection site problem, in some people, a little bit of pain due to injection, but these are almost painless injections. And the rest of the a couple of complications are so rare that should not be talked about. As far as the other drugs are concerned, SGLT2 inhibitor, which also lead to some weight loss, a urinary tract infection in around 2 to 3% of the patient is the only side effect. Otherwise, there's wonderful drugs. So actually, their positive effects far outweigh the negative effect. And so but any of the side effect must be understood by the patient. So you must have a conversation with your doctor if you are going to take drugs and ask all relevant questions. I'm sure your doctor will be able to answer all. And once you are convinced, then you take these drugs. But I can tell you, we know about all side effects, and we can tell you that these side effects are not occurring in too many people, or they are can be well managed.
That's very heartening to know because I think people should go with the science and go with what is proven instead of taking chances with the health which later they may regret. Dr. Sujay Ghosh, what are the benefits of weight loss in the type 2 diabetes patients in terms of the long-term cost saving and the quality of life?
Right. I think this entire program we've been talking about how the weight and the glucose control seems to go hand in hand, and how both of them are actually interrelated. So, like Professor Mishra said, that in the past we were more, having a tunnel vision that, you've got to get the blood glucose down to a certain target. We were not even thinking of other organs, and we were not even thinking of weight. So we now know that we've actually got to decrease the glucose level to a near normal level at the cost of lowering the body weight. We can't have a situation where you have the glucose perfect, but you've not done anything to the weight, or you've made things worse. So if we are able to actually cut down the blood glucose values along with maintenance of adequate weight or reduction of weight, then we've actually won more than half of the battle. Now, to do that, of course, we have to have good lifestyle changes in habits, which are relatively more difficult to actually practically implement than, it's easier to discuss and say. And of course, about the drugs. And Dr. Bansi already mentioned that these newer drugs are going to be more expensive than your more traditional, conventional medication. Now, when we talk about costs of therapies or benefits of therapies, there are two ways of looking at it. One is the direct cost. So drug A versus drug B, how much does it cost? And the second is the indirect cost. For example, you're trying to look at how many heart attacks have I been able to prevent? How many people have we been able to prevent from going blind? How many people have not lost a foot due to an amputation due to diabetes, or not had a liver failure, or not had a premature death? So those would be indirect costs, and more importantly, sick days lost at work. So if you are so ill because of poor blood glucose control along with X, Y, and Z complication, you will not be able to go to work and earn. So therefore, when we talk about cost-benefit analysis, we do what is called a DALI and a QALY analysis to look at, a particular treatment A versus particular treatment B. Is this more cost-effective than the other? And it's quite clear that the direct costs of the newer drugs might be more, but when you're looking at overall cost, which takes into account the indirect costs, the quality of life that we are talking about, it's clearly superior that if you are able to improve glycemic control along with weight management. The two are both equally important targets. And I was just mentioning in one of the questions that you had asked previously that if you put on 3 kilograms of weight, it offshoots the benefit of 1% reduction in HbA1c.
Right. Dr. Sabu, uh, uh, we've seen Dr. Sujoy give us a complete math of why it pays to, get your weight in check and the cost involved. Now, he also said that, lifestyle changes are a little difficult to keep up with in the long term. And when it comes to weight loss, what are the different available options for weight control which are currently available?
Currently available for lifestyle modification?
No, sir, for weight reduction.
So weight reduction, the medications which are available to us at present, you are talking of those weight reducing medication you are talking of?
Yes, sir. What are the options available?
So at present, other than these anti-diabetic medication, which we were talking of GLP-1 and SGLT2, as I told you already, there are dedicated GLP-1 molecules, which are now we are researching in field of persons with obesity also. As Sujay was already talked that these medications, which are available in some parts of the world, and they are using it also in off level also, these molecules for weight reduction, and there's a significant weight loss, which is like almost like 10 to 15%. And now there is a GLP-1 and GIP combination, which is available at present, tirzepatide, which is available in US market, which is again for diabetes and obesity, and found to have weight reduction of even up to 15% to 20%, or even more than that in some of the selected patients. So we have these wonderful molecules which are going to come in near future to our country also. And maybe in another 5 years or 6 years, we will find a lot of these molecules which will be available in oral form, in injectable form, in once in a week, and maybe in once in a month. So, the less number of injection. Only challenge will be will be costly, because these will be the newer molecules. They will be having patent rights, and that may be the only challenge for us. That could be one of the biggest roadblock for each and every patient may not able to afford these patients, because in India they have to pay from their pocket. It is not like that insured market on a OPD basis. Again, obesity is not considered that as a disease, or even the third party insurance, even they take, it will not get reimbursed by them. But these are the molecules which will be available for us, and I'm sure these molecules, when will be used for long term, the 10 to 15% weight reduction for many of our patients will be, a dream will become true. For 5% weight reduction at present, 5 to 10% with lifestyle modification, and the currently available GLP-1, which is available to our country, many of our patients are getting that benefit. So 5 to 10% weight reduction, many of our patients, they get easily.
All right. Dr. Mishra, you had said that the newer age drugs are not just focused entirely on glucose control, but they are focused on organ preservation and organ safety. So, can you tell us a little bit about are there any guidelines which have been changed and now giving more importance to weight management and type 2 diabetes?
Okay. The guidelines, very interestingly, the guidelines that we made for Indian population some time back were entirely on the weight. For diabetes management, entirely bifurcated based on the weight. Those who are obese, different sets of drugs. Those who are non-obese, different sets of drugs. And this was quite some time back, and no other guideline anywhere in the world actually has looked into, at that time, looked into the diabetes management based on weight alone. Now everybody is talking about it. So, but if you look at the chart of the American Diabetic Association and European Association of Study of Diabetes, then still there are multiple bifurcation, which makes sense also, because one is based on existing heart problem, what you should use there. Other is existing kidney problem, what you should use there. Other is weight and diabetes, what you should use there. Fourth is cost, what you should use there. And fifth is those who have tendency for low sugar, what you should use there. So this is a very reasonable type of chart, and where obesity is one of the components, but actually the drugs which you are going to use for obesity are also being used for cardiac protection and kidney protection as well. So the drugs which Dr. Bansi Chabu and Sujoy have been talking about, GLP-1 receptor and also SGLT2 inhibitors, come in almost every category except for cost-wise category, where low-cost options are there. That is category where these two drugs are not there. Rest, they protect heart, they protect kidney, they decrease weight, and also very importantly, and which we have not talked about so far, is that they have low tendency for low blood sugar. Now, low blood sugar plagues several patients frequently and some patients infrequently. The moment low sugar occurs, patient has such unpleasant experience and has then high tendency for going into a cardiac problem or a neurological problem. Has to be avoided at all costs. And these drugs are fairly safe at that. So you can see how with one arrow we are hitting multiple targets here, and which is something, again, I repeat my previous sentence, magical. Magical. These are almost magical drugs. But nonetheless, their use cannot be generalized and they have to be used judiciously. A good physician who knows about the drug and knows about his patient will utilize these drugs judiciously.
All right. Dr. Sabo, what do these guidelines say about the amount of weight loss that can help a person with diabetes have a better health outcome?
Sorry, what guideline says? I'm sorry.
About the amount of weight loss that can help a person with diabetes have a better health outcome. But Dr. Anup Mishra explained how the guidelines talk about, different organs involved, what is the protocol, and the different criteria that are there.
So as you
Anything
know,
about weight loss, how much weight loss will help with the person with diabetes for a good outcome?
So, the two things are there. One, Sujoy had started with that, what is the baseline weight? We recommend for each and every therapy which we are writing to our diabetic patient, it should have a glucose control benefit. It should have a benefit to prevent the complication, which is the cardiac and kidney benefit, the liver. And it should also have a benefit that it should not increase the weight, rather it should have a property to lose the weight. Now, the baseline weight is how much? Suppose someone is having a baseline weight of 100 kg. The BMI is almost like 30 or 30 plus. Now, with the person with a weight loss of even with a 5% weight reduction, there is a metabolic profile which improves. Metabolic profile means there will be some improvement in lipids. There will be some improvement, better improvement as far as glucose is controlled. So all metabolic profile is improved. Even the blood pressure will be better controlled. The cholesterol will be better controlled. When weight loss will be between 5 to 10%, these metabolic profile plus the other part like osteoarthritis, the pain or the obstructive sleep apnea, all other the complaints related to the because of obesity, all will help. But if there is a weight loss of more than 15% or 15% plus, there will be partial remission or the sugar control will be more and much more better. So what we recommend in the guideline is the medicine which we are giving along with the lifestyle modification, the person should lose the weight. The ideal body weight is again minimum, they should have minimum weight reduction should be 5%, but 10% is a desirable weight loss That what we are recommending if someone is overweight to obese person. For morbidly obese mean BMI is more than 35, where Dr. Anup Mishra had recommended, and now for Asian recommendation it is not more than 35, even more than 32.5, and we call obese person also more than 27 BMI. For those person, the weight reduction more than 10% will definitely help. But for morbidly obesity, even for 15% or 20% weight reduction will give a significant benefit, not only for glucose control or for reduction of the medication, but for other complication prevention also. So the guideline is saying definitely weight reduction is preferred. 5 to 10% is desirable up to the person with a BMI of 30.
Can I make a point here?
Yes,
Yes, sir.
please go ahead, Dr. Mishra.
I think that answer was excellent. What we tell our patient is our primary goal is you should not gain weight, number one goal. And number two, you lose whatever weight that you can. 1 kg, 2 kg, 3 kg, 4 kg, the larger the better, but even 2 kg is okay. Why? Because even losing 2 kg is difficult. And if they lose this much, a little bit, they will benefit. Number one. Number two, they'll be vastly encouraged because till now weight has been increasing and that trend is arrested and it has decreased. So besides whatever Dr. Banshi Sabu says is absolutely correct that the larger it is, the more benefit. But even a small weight loss will be good.
All right. Dr. Sujoy, the ADA-EASD consensus report was published recently. Could you give us a brief overview of this report, what it says?
Right. So I think the first bit has already been discussed, which talks about that weight loss should be one of the goals of management of diabetes. So in people with diabetes, weight becomes an important primary criteria where you should try and target a weight loss of 5 to 15%, at least about 10%, which Dr. Bansi has already told us. That helps overall in the progression of the disease, the complication of the disease, and disease adjunct. It then talks about that you have to think of certain lifestyle interventions and behavioral changes, something that we don't talk much about. Perhaps even the inclusion of a clinical psychologist along with a diabetes educator and a dietitian or nutritionist to actually do that. The third would be when we are choosing medication to manage hyperglycemia or blood glucose in diabetes, we need to prefer certain agents over the others if we are talking about people with diabetes with obesity. And that would include the GLP-1s and the SGLT2s. And of course, we'll talk about avoidance of certain drugs. And like I said, we would talk about a dual target rather than a single target of blood glucose. We talk about a target of glucose along with weight reduction. And finally, in certain individuals, we might need to go for metabolic surgery. Not that it's the thing that we would want to go ahead in all of our cases, but in certain circumstances, we would not have a choice. And the Western guidelines kind of suggest, a BMI of 40, even if you don't have diabetes or other comorbidities. In India, the cutoffs would be lower, maybe 37.5, or if you are looking at people with obesity with comorbidities, the Western guidelines would talk about a cutoff somewhere around 35, whereas in Indians and Asians, we would talk about a cutoff of 32.5. But again, remember, BMI can be pretty treacherous when you're actually evaluating obesity. That's something that we've not discussed here. A lot of people have smaller body frames, but with much higher proportion of body fat. So in near future also, I think we will probably start talking about characterizing body fat, obesity, and overweight in terms of proportion of body fat rather than body mass index cutoff. So that's something else that's probably going to be important as well.
All right. Dr. Mishra, can you talk to us about the drugs that we have heard very often on this show, which is the GLP-1 RAs?
Okay. So GLP-1 receptor agonist were the drugs initially discovered by a very interesting way. A lizard which was found in some of the American mountains, Gila monster. It's a saliva contained substance which led to decrease in the blood sugar. So that was exending 4 initially, and then subsequently number of other agents were manufactured which were in an artificial manner. So there were some drugs which are based on that Gila monster exending 4, and some drugs which are manufactured artificially. Both types of drugs are available. Most of them are injection, and one which has been orally now can be given is now available in India. The way they act is through secretion of insulin and suppression of appetite and changes in the intestinal movement. So they act on the brain, they act on the intestine, they act on the pancreas, multiple ways they are acting. And by acting in this manner, they decrease the glucose and they also decrease the weight. And they have action on the heart cells in a manner that these damaged cells can be repaired, and also have some action on the liver cells so that the fat in the liver does not damage the cells and the liver becomes better. So initially when they came around almost more than a decade to 15 years back in India. And at that time, we had injectable drugs which have to be given twice a day, and then once a day, and then around 5 years back, 6 years back, once a week injection, and then this oral drug. This is the progression of these drugs. Each one has its own property. Each one has its own action on the heart and the liver and so on. Not every agent is similar. Some are more potent than the other, and some which has been talked about recently. There's some more which are available in the United States which are more potent. So right now, if you go to a physician having two concerns. Number one, you're obese, non-diabetic, or you're obese and diabetic. These are two different concerns. In obese, non-diabetic, what are the options? Options are an oral drug called Orlistat, which has been available in India for several years now. That's not GLP-1 receptor agonist. There were several other options which came and went because of side effects. And then off-label means Government of India does not allow injectable GLP-1 to be used as weight loss drugs alone in patients without diabetes. And then you explain to the patient that they have been available in the United States and FDA has approved it. And here I'm giving you off-label. And several times we have used such drugs primarily for weight loss in patients who are not diabetic. In diabetes, it is simple. All these drugs are indicated in patients with diabetes. Now, whether you want to give once a day injection, you want to give once a week injection, or oral drugs, it will depend on the physician, preference of the patient, and the desirable action that you want to see. So in short, excellent drugs, excellent for weight loss, so many choices available in India, and a wise physician will do the best for his patient by choosing the right kind of drug.
All right, we're coming to the close of this session, and I would like to take some concluding remarks from all of you. Dr. Suja, you can go first. These drugs, the way they work and the way they've been described to even protect your organs beyond just your diabetes, they really are miracle drugs. So what's the future for obese people who have diabetes? Very quickly, you can give us your concluding remarks.
Right. I'll probably try and answer that into two parts. In terms of medical options that we have or that we will have in the near future in terms of management of obesity, these are exciting times. We probably have great options, or we are going to have, say, in January of next year as well, the injectable ones perhaps. We have more options than we ever had before, which helps with the management of the obesity, the diabetes, and organ protection all in one go. But remember, if we are really wanting to tackle the pandemic of obesity, drugs are not the option.
All right. Lifestyle changes remain quite important. Dr. Mishra, what would you like to say in your concluding remarks?
I would say that, as Sujay has in the last sentence said, for the prevention, we have to focus on prevention of obesity, and that starts from the childhood, from the school. If we prevent obesity, we'll prevent diabetes, and we prevent the drugs certainly will be used much less. So first thing is in the right kind of diet and right kind of exercise, starting at class 6 onwards, and education of the parents so that their children do not become obese.
All right. Start early. That is the advice that Dr. Anup has. And Dr. Sabu, what would you like to say in your concluding remarks?
I fully agree with Dr. Sujoy Ghosh and Dr. Anup Mishra. I will go with further that start early. Rather, we should act before that to have a normal birth weight of a newborn. So start with from that, because in India, the problem is a paradox, which we are having a low birth weight child and then feeding the child so much, and then the child become obese, and that these are the children who become in their adult life having more non-communicable diseases. So making healthy moms, so a healthy mom will have a healthy baby, and healthy baby with a healthy environment. So it's a healthy environment is going to prevent the obesity. Overall environment we have to create in such a way that the children, the young adolescent, and everyone will not have the obesity. So the prevention of obesity should be from all the angles. Everyone should be more conscious about it, from the childhood, from the school, from the environment, from the working place, everywhere. And that's the right answer, rather than going for the drug or therapy. Yes, definitely for some cases the treatment is always required, but prevention of obesity is the key, because it can prevent many more diseases.
All right, we'd like to thank you, all our doctors who have joined us for this session in our prevention of obesity summit. Thank you so much all for joining us, Dr. Sujay Ghosh, Professor Dr. Anup Mishra, Dr. Banshi Sabu. Thank you all for joining us today on this very critical summit that we have on obesity prevention and the linkage that it has and the impact it has for our diabetic population. While medicine is making great strides, we must also make our own efforts in terms of lifestyle changes so that we can prevent obesity, and hence, after doing that, we will be able to prevent many such non-communicable diseases, which will help reduce the burden on our healthcare system. Thank you all for joining us. And this is the message of the Obesity Prevention Summit. Take care of yourself now. Don't put it off, because it really pays. Thank you so much.
Thank you.
Thank you.
Thank you.
Thank you so much.